Uh, Thank you very much, Jonathan. I'd now like to introduce Dr. Wagner, Dr. Ed Wagner from Seattle. Ed has been an important influence in my life, more than he realizes, for the last probably 10 years, since I first heard about the Wagner chronic disease model, which even many years ago was adopted as the model for the management of chronic illness by the Royal College of Physicians and the Royal College of General Practitioners. I think the time at last has come where there's a wide enough consensus across the whole of our society that this is something we need to pay attention to. So it's absolutely appropriate that he should give our keynote lecture. There are a number of good things that come out of Seattle. There's the coffee. But as Jonathan probably may know, where Jonathan's gone to, the Belding Scribner in Seattle invented the scielastic shunt that made hemodialysis possible. I used to be a nephrologist. But no better things than Dr. Wagner. He once described his model as the best of British general practice, scaled for purpose. Dr. Wagner.
Thank you. It's a real privilege to be here, and it's a particular privilege to follow Jonathan Hope, who I think set the stage for what I hope will be an exercise in patient-centered policymaking. What I would like to do in my few minutes is to really follow what Mr. Hope talked about, which is building up policy from patient needs. My work and our work has always been focused on the ground, where patients and healthcare providers come together. And it's been based on trying to figure out what healthcare can offer to patients to improve the outcomes that matter to them. From understanding patient needs, then our job as professionals is to identify those services that evidence suggests best meet those patient needs. And then once we understand patient needs and the services that help patients meet those needs, then we have the basis for designing policy. And the goal then would be to create those incentives and structures and organizational relationships that increase the likelihood that those evidence-based services will be delivered systematically and routinely so that patient needs are more likely met. So our work began with really trying to identify what patients with long-term, I call them chronic, that's the American term. I think long-term somehow sounds less stigmatizing. But so do you prefer that, jury? Long-term. So we'll call them long-term. So what do patients with long-term conditions need to optimize the outcomes that matter to them and to us? As Mr. Hope said so well, they need first support and information that enables them to become competent self-managers of their own health and illness. They need the skills, they need the information, and they need the confidence to go home and make wise decisions. And with appropriate information and help from relevant health and social care providers, they can become competent self-managers. Second, they need obviously effective clinical, behavioral, psychosocial interventions that keep their conditions under control and optimize the quality of their life and their health status. That's obvious. They need effective preventive care preventive care that is determined by their age and gender, as well as preventive care that is determined by their conditions, to reduce the risk of complications and other morbidity. And increasingly, the evidence is suggesting they need ongoing monitoring of the patient's condition. And often that monitoring can be done by the patients themselves to detect and enable a response to problems, complications early in their course before it becomes too severe. So the chronic care model was really built on that basis, identifying patient need, looking at the interventions that lead to meeting those needs more systematically. And on the left are some of the sort of central features of the chronic care model that emanated from the evidence: self-management support, team-based care, physicians that try to meet all those needs that I identified on the earlier page by themselves almost invariably will fail. There's just too much to be done. Physicians have often neither the time and in many cases the skills to meet all of those needs. Building a team around providers increases the likelihood that those needs will be met. Planned proactive care. People with long-term conditions don't want or need urgent care responses. They need a more forward-looking, proactive health care that is looking to the future and enabling them to be better prepared for the future. And then finally, they need organized follow-up. Increasing evidence is suggesting, again, that monitoring and continual communication back and forth of how patients are doing is essential to keeping them healthy and optimizing quality of life. But we're all concerned about the complex, multi-morbid patient that Dr. Chandler talked about, the one with 4 or more chronic conditions, because they are most in need, and they are consuming a huge proportion of the healthcare dollar. So they are of legitimate concern. Those patients, in addition to the 4 needs that I previously mentioned, also need or increase, shall I say, increase the need for an effective primary care house of care, we call it a medical home in the US, where somebody has whole person knowledge of the patient. People with multiple conditions who are receiving care essentially from strangers who don't know them as individuals, I think, are at a disadvantage. We need, though, integration of primary care with behavioral health, that's mental health and behavior change services, and social services. And then, in addition to integration, and we'll talk about a distinction between integration and coordination, they need those services coordinated for them, for individual patients, not just at the agency level. They need clinical care management. The evidence is now mounting that more intensive management between physician visits with the help of a nurse, care manager, or other health professional while the patient is in the home and at work increases the likelihood of better outcomes for people with these multiple chronic conditions. And then greater sharing of care between primary care and specialists, between medical care and social care, leads to better outcomes. What works in sharing? The evidence is now strong that sharing really means interactive communication among the people caring for a single patient. So it's not just enough that the organizations that everybody works for are somehow organizationally connected. The individuals caring for individual people must be connected and talking to each other. So service integration, and I'm not trying to convince the British that to accept my definition of these terms, but I want to make a distinction between what I would consider service integration, which is establishing the infrastructure, the structures and relationships that facilitate coordinated care. So having people in the same building, having agencies have organizational relationships, all of that is very nice. And it probably facilitates what I would call coordinated care. So what is care coordination if it's different? Here's my favorite definition of care coordination, and forgive all of the use of the word integration here. But care coordination is the deliberate integration of patient care activities between two or more participants involved in a patient's care to facilitate the appropriate delivery of healthcare services. So it is a deliberate set of activities to try to make the sharing of care more seamless and less dangerous for patients that are moving from place to place, provider to provider. In our studies of care coordination, we have looked at what the best organizations are doing to coordinate care, and invariably they all were doing something in 4 areas. One is the assumption of accountability, which means that the parties involved in the care of an individual assumed accountability for making that care seamless. So make sure that patients were not having frustration or even mishaps because providers were not communicating appropriately with each other. Second, they realized that care is best done when individuals caring for the same person are actually talking to each other and understand each other's expectations. Care by strangers is, I think, somewhat dangerous. So building, and in the US, rebuilding relationships that used to exist but have been fractured by recent policy changes is a critical element of care coordination. Third is building connectivity so that information can flow easily and completely between the various parties caring for the same patient. Shared medical records, of course, is ideal, but there are other alternatives in the absence of shared electronic records, such as web-based electronic referral systems. And then finally, patient support. Support patients through the process of moving from provider to provider, institution to institution, so that when a patient leaves the hospital, they don't suddenly be thrust into the community without some bridge having been built back to community care. So that's care coordination, and I hope I've distinguished it from what I consider integration, which is more of a structural issue. A critical need of particularly the complex, more severely ill individuals with long-term care is this issue of care management. And we've learned a lot about care management over now 20 to 25 years starting with the work of disease management companies and so on. And we've learned that care management does work, but under certain circumstances. And it's important to understand the difference between care management that works from care management that doesn't. Care management that works is more effective when the care manager is an integral member of the team caring for the patient. So having a care manager in an office building in a remote community who's phoning up and working exclusively on self-management, independent of knowledge of or influence over the medical treatment, has been shown to be ineffective. Second, there is evidence to suggest that care managers are more effective, have a more positive effect on outcomes if they have the knowledge and authority to influence medications. That doesn't mean they have to have prescribing authority. It means they have to have sufficient understanding of the patient's complex drug regimens that they can make recommendations to the treating physicians to make appropriate changes. And then lastly, there's evidence to suggest that care managers are more effective when they have access to the relevant specialists pertinent to the particular patient population they are serving. So we've been working with care management for patients with cancer, and they find meeting with an oncologist once a week to discuss the issues and questions of their patients greatly strengthens their ability to be useful. Finally, I think true integration of care that will help meet the needs of patients with long-term conditions will mean a greater partnership and a potentially different way of working between primary care and specialty care. And as I indicated earlier, the evidence is now overwhelming that sharing care, and the UK pioneered the notion of shared care 25 years ago. But the shared care particularly is effective when the individuals sharing the care of a single patient are actually talking to each other. Not just passing notes back and forth, but actually communicating. The communication can be electronic. Nowadays, it can be by secure email message. But when they're talking to each other, better things happen. Messages to patients are clearer, decisions are crisper, and it avoids the awful tragedies of failed communication, such as duplicate medications, interacting medications, and other medical mishaps. So I think we now understand, and Mr. Hope helped us understand even more clearly what patients with long-term conditions need from health care. I think we have an evidence base upon which to build effective policies for long-term patients. We've got to pay particular attention to how to manage the multiple services that patients with multiple conditions invariably need. And that's, I think, the great policy challenge. If any country can do it, the UK can. Thank you very much.
We'll have an opportunity to discuss this at the end of the presentations, which will be led by the patient jury. Martin.
Thank you, Cyril. I'd just like to thank Ed Wagner for coming and sharing his thoughts and insights. It's actually a thrill for me to share a platform with him. He's been so influential in guiding my thinking and giving me insights about how we need to reorientate our health and care system to meet the challenges of the future, not those of the past. That's why we're holding this conference. One mind alone is probably insufficient to rise to that challenge. But we live in a new era, an era where information is constantly at our fingertips, where communication is easy and hugely interactive, where it's entirely possible, in fact desirable, that we should harness the power of the collective mind to address the problems we face. If you haven't seen it, go to the web, look at the document NHS England published last week on transforming participation in health and care. This sets out the new way and ways we need to work with and unleash the potential of the people we serve, as well as harness the potential of the professionals within the system. I was trained, and I know this will be impossible to believe, before the internet. I trained to be the expert, the repository of knowledge and experience that people would come to for advice and help and care. I was trained to believe that invariably there was a singular diagnosis, and by applying my intellect and skills, I could make that diagnosis and offer a cure. I was trained to be autonomous and accountable for my actions and inactions. I was trained to meet the challenges of the 20th century, the challenges of the past, and those challenges have changed. We're all aware of the demographic changes. People are living longer, and let's not forget that an awful lot of them have a good quality of life. And the changes in demography have been accompanied by a change in disease patterns. And those changes have been accompanied by huge societal changes. Beliefs, attitudes, and expectations have shifted enormously. So the NHS can either act like King Canute, or we can roll up our sleeves and be innovative, adaptive, and accept that change happens all the time, and we need to work with it, not fight it. We need to help shape the future, not fear it. This was brought home to me by colleagues in general practice a few years ago when I talked to them about care pathways for single conditions. They looked at me wearily and reminded me that the people that they saw day in, day out did not have diabetes. They did not have heart failure. They did not have depression. And they did not have arthritis. They had diabetes, depression, arthritis, and heart failure. They could make a pathway fit a person. The trouble was, the whole patient didn't fit a pathway. Thanks. It struck me that we had a system that wanted people we served to fit the care we wanted to provide. That, I believe, is a broken model. What we need to be thinking about is how we fit care around a person. Analysis after analysis reveals the emergence of comorbidities, multiple conditions being the challenge for the future. We should not discard the successes and progress we have made, but we need to prepare for the complexity of the future. We need to make care person-centered. After all, that is what the people we serve have said they want. If you've not been to the National Voices website, please could I urge you to do so. The work they completed a year ago has informed and influenced the work we've been doing in NHS England. I make no apology for reading out verbatim a statement from that website about what people want. They want that their care is planned with people who work together to understand me and my carers, puts me in control, and coordinate and deliver services to achieve my best outcomes. That is the starting point for the House of Care. This is what we're here today and tomorrow to help shape and design, and I hope ultimately build, a new model for the 21st century. The House of Care is a model, a metaphor to help construct a system and support personal interactions. It recognises and acknowledges the complexity of the system. There is no singular action, no magic bullet, which will solve the complexity of the care we need to be able to deliver. The foundations of the House of Care are built on commissioning. I've been involved in commissioning for about 20 years now. I'd like to reframe what commissioning is in people's minds. We need to look at it as a quality improvement cycle. Plan, do, study the impact, and act to plan differently if we're not delivering the outcomes desired. Note I said outcomes. Inputs and process is important, but process must always be linked to purpose. Our purpose as commissioners is to deliver high quality care for all. Quality which is constructed from safe, effective care with a positive experience. Effective care which prevents premature, unnecessary mortality, enhances the quality of life for people with long-term conditions, and helps people recover from episodes of acute care or trauma. Some of you will have spotted that I've just set out the link between the NHS outcomes framework and high-quality care for all. The NHS has taken a really bold step to put outcomes central to purpose. In commissioning, we must also deploy the best practice, clinical and organisational, available to us, as Ed has already alluded to. We are envied by many other health systems in the world because we have NICE. We must continue to use guidelines and standards intelligently to support high quality care, and this is what we will use to build the roof of the house. But between the foundations and the roof, we need two strong pillars to create the space for person-centred coordinated care. The first pillar is to give people and carers as much control as they want. As a clinician, I might have seen a person with a long-term condition for 5 hours a year. Their carers will see them daily. They, the individual, will live with it constantly. So who needs to be in control? Who needs to be as expert as possible? Who needs to feel that they can get the support they want to help them live the life they want and meet the goals they set? I was fortunate enough to meet Penny at the launch to this conference, and she recounted her life since she's been paralysed following a riding accident, and how much she's had to work against the assumptions, perceptions and decisions made about her and for her by professionals, about the inordinate difficulty of navigating the system over several months to replace a £200 Velcro strap on her hoist, a process which she calculated cost the system tens of thousands of pounds, let alone the problems it caused her. Recently, I met her on a train heading up north, and she mischievously recounted how since our last meeting, she decided to get a kitchen redone and decided to let the care system know about that. A panicky professional exclaimed, "Well, we'll have to move you into a nursing home. You won't be able to cope." To which Penny dryly replied, "I manage quite well when I go to Africa." Please, can we build a house of care that gives people the control they want of their care and their lives? And the final pillar, again, to echo Ed, is professional collaboration. I was trained to be an autonomous individual heroically curing people. That era is over. We now need to work in teams. We need to collaborate, generalists and specialists, doctors, nurses, allied health professionals, pharmacists, volunteers, communities, social workers, mental health professionals. Professional collaboration needs to be supported. And I read an article by Jeannie Haggerty recently in the BMJ, which talked about continuity having 3 components, and I think this echoes what you've been saying. Informational continuity. The information about a person is available to them and to their professionals wherever they are. Management continuity. We design management systems to support continuity of care. And finally, relational continuity. There is a professional who is a trusted advisor and known to that person. But also, I don't think that goes far enough. I would echo what's just been said, that we need to support professional relationship continuity. The best care I ever gave was not only due to the continuity of relationship I had with individuals who I was caring for, but also with my colleagues, the experts I called on to help to deliver person-centered, coordinated care. This is why we need to build that pillar that supports that collaboration, that team working, and understands that transactions and processes are important, but the pillars of care are built with human beings and with humanity and cemented by the values and principles which are what attract so many people to work for the NHS and care. Thank you for coming to this conference. Thank you in advance for your contributions, and thank you for the hard work and dedication you have given and will be giving into the future for the NHS and to build a house of care. Thank you.
Then lastly, can I invite Jeremy Taylor to talk to us?
Just to forestall any mischievous tweeters, yes, another middle-aged white man takes to the podium. Sorry about that. Not great for diversity, is it? Can I echo others in saying it is a privilege to be able to address such a big and well-informed audience and to talk about things about which most people in this room are greater experts than I am. So it is a privilege. And thank you to Martin for your very generous name check of National Voices and the really fantastic work that we were able to do with service users, patients and organisations that represent them to develop a narrative, a vision for what good coordinated care really looks like. Very similar to the chronic care model that Ed described, but perhaps with a bit more of the voice and centrality of the service user at the heart of it than I think you described, Ed, if I may be just slightly cheeky in critiquing your model. So I think I don't have any of my own slides. I'm going to shamelessly steal other people's. Can we go back to the House of Care? It's just like having it up. Can I do that? I don't know. I can't operate this. You know what it, that's it. So in a way, perfect scene setting from the previous two speakers. We need to build the House of Care. And I think my comments are going to be about how we can do that. The House of Care is a wonderful metaphor. It takes stuff that people have been talking about and researching and giving evidence about for many years, and Ed is one of the foremost amongst them. It takes it and puts it into different terms, gives us a rallying cry, if you like, gives us a call to action. And the call to action, I think, should be, let's go and build houses of care across the country. We, as National Voices, have been at the forefront, if you like, of that house-building effort. For those of you who don't know, we're a coalition of about 160 health and social care charities, and our job is to, one, be an effective umbrella for those organisations, and two, to be a champion of person-centred care. We've done a lot of work in this area. We lobbied for a legal duty for commissioners to commission services that give patients a real voice in their care, the duty of patient involvement. That's a new one, and we're very proud to have been involved in that. We've worked on the narrative of person-centred coordinated care that Martin referred to, and tomorrow we're going to launch a further iteration of really important work we're doing on what does care and support planning look like, that circle in the middle of the House of Care. How do we actually make it a reality with people being fully involved in the care planning process, not just having a plan written about them that they never see and which may not be shared with them or indeed across the multidisciplinary team. So we want to see these houses of care built everywhere. And I want to ask, what stops that happening? What are the obstacles to overcome? I think there are three things. There are lots of things. There are three things that I want to highlight that I think need to happen. First of all, I think we need what would be the equivalent in a large house building program, planning permission. But in policy terms might be described as a consistency of purpose from government and the NHS all the way through the system. I don't think we have that consistency of purpose yet. And I just want to quote something. I'm a real last-minute deadline junkie. So I was actually composing this morning. Big confession. But the advantage of doing that is you pick up things at the last minute. And there was a fantastic link tweeted by somebody to a BMJ article from earlier, last month. And it was about quality of care and efforts to improve quality and the obstacles to that. And I just want to quote from the abstract, because I think it says a lot. Consistent achievement of high quality care was challenged by unclear goals, overlapping priorities that distracted attention, and compliance-oriented bureaucratized management. The institutional and regulatory environment was populated by multiple external bodies serving different but overlapping functions, and so it went on. Does that sound familiar to you? I think you'd probably find it does. And I think we're in a situation where there has been a massive reorganization of the health service that frankly has had very little to do with the agenda we're talking about today. And which is still bedding down. We have lots of things going on. The Secretary of State has launched a vulnerable older people plan. He's refreshing the mandate to NHS England. NHS England has issued a call to action There is a national integrated care collaboration that we're quite strongly involved in as National Voices. There are lots of things going on, all quite similar, all overlapping, but not entirely consistent. We've got a whole industry of reviews and reviews of reviews following the disaster at Mid-Staffordshire and some other areas. There's an awful lot going on, too many initiatives, and they're not aligned. So let's take House of Care, let's build a House of Care as a really good call to action that can align all these similar but unhelpfully overlapping initiatives and get some consistency of purpose about creating a health and social care system that genuinely works for the people who now need it. So that's my first thing. Second thing, we really do need a consistent drive to create a wraparound out-of-hospital service that addresses people's health, social, practical and psychological needs. We know this, we've all been talking about it for many, many years, and we don't have it yet. We need to bring together the best of UK general practice in Ed's term, and community services, and pharmacy, and social care, and public health, and the voluntary and community sector, and communities themselves, working together to create that wraparound out-of-hospital service. It's not that we no longer need hospitals, but we need something that helps to keep people out of them in a much more consistent way. And I think that that is another way of conceptualizing the House of Care. It is building the equivalent of hospitals, but homes of care for people outside hospitals. It's a bit like a prefab. So, you know, most of the elements have already been manufactured. They just haven't been assembled in a way that creates a consistent offer. And they need to be assembled, and we need to get on with it. And part of that is money. So it needs investment. And what's happening at the moment is that the money is going in the wrong direction. So money is coming out of general practice, money is going out of community services, money is going out of social care, and it's going in to prop up hospitals that are creaking under the strain. So the flow of money is absolutely in the wrong direction to the flow of policy, and that cannot be right. And that, you know, the government and the NHS leadership and all of us need to kind of grip that and do something about it. My third point, which is maybe the most fundamental one, if we're really going to build houses of care, we need a different view of what is often called the patient, where I think the very fact that we've got a people's panel rather than a patient's panel says a lot about how we need to reconceptualize the role of people who are using services. So there's an odd paradox here because the rhetoric about the centrality of the patient has probably never been stronger. It's really ramped up in the last few years. So you can't move without encountering a new document that tells us that patients are at the heart of this, patients first and foremost, putting patients first, patient-centered care, and it's always patient rather than people, although increasingly we're hearing the word person. Still lots of patients. But as I'm sure the people on the jury, I'm glad you're not really a jury because I'm worried about the verdict, would agree, there's a difference, there's a gap between the rhetoric and the reality. And I think if you look at where the energy of policymakers has been put, it's in two aspects of putting patients first. One is what I would call dealing with the problem of patient as victim or potential victim of harm, for very understandable reasons. Bad things have happened in the NHS, and it's absolutely right that politicians and policymakers look to how we can prevent bad things happening. So we've had the Francis Review, 2 Francis Reviews, and lots more reviews. And we've had a current policy that I would summarize as protect and inspect. We need to make sure that bad things don't happen. We need to reinforce our regulatory and inspection regimes and make them fit for purpose. And I think there's a lot of strength and a lot of necessity in that approach. But we are at danger of putting too much weight on the importance of inspection. And ultimately, that whole agenda is disempowering. It reinforces the powerlessness of vulnerable people rather than talking up and reinforcing the power of people to take control. So it's a necessary but not sufficient aspect of putting patients at the heart. The other really big current of energy, if you like, in policy making has been strengthening the role of patient as consumer. We need a more customer-friendly service. We need a more responsive service. People need to have choices. They need to have better information to make choices. They need to be able to rate their carers. They need to be able to read the ratings on websites. They need to be able to fill out the friends and families test. I make no comment on whether that's a good thing or a bad thing. I think there are elements of consumerism which are necessary, but I think the patient as consumer is only one aspect. So we need a different mindset. The thing that we really need to get our arms around is stopping talking about patients as patients, thinking about people living with long-term conditions, thinking about everything that Jonathan told us at the start. So we need a mindset that's about people with long-term conditions being partners in decisions and being their own care managers. And we've heard some other metaphors around pilots and airlines, very interesting. Where the care team is me, the service user, and my family, and my friends, maybe my neighbours, and my carers, and where the job of the health and care services is to support my team to be successful. I had a little quote from our narrative, but Martin has already done it. I can plan my care with people who work together to help me achieve my outcomes. That's what it's about. Not, as to quote from another tweet that I found today from a patient leader who will be well known to some of you, David Gilbert. As a patient, I could help my GP, but instead I'm offered a bloody survey and treated like an idiot. There's too much of that still, and not enough of embracing the notion of people with long-term conditions as partners, as co-decision makers, as managers of their care, but needing the help and support. So we've been talking about this kind of stuff for an awful long time, it seems. I've only been in this business for about 4 years, but I deal all the time with people who've been working in the healthcare system for 20 years, 30 years, knowing that we need to do stuff in this area, and it's happening, but it's happening incredibly slowly, and we really need to kind of pick up the pace. We don't need more policy. We don't need more initiatives. We need implementation. We just need to go out and build those houses of care. Thank you.
Right, we have a little time for the People's Panel to start asking questions. I mean, it's always very nice to hear the evidence base for common sense, don't you think? Anyhow, questions, comments? Ma'am.
I think it's more of an observation. Firstly, it's been a pleasure to hear Ed speak because we know a lot about Wagner modelling and how it works. And everything that has been said so far.
Can you speak up a bit, dear?
I don't know whether it's actually on or not.
I think so, if you speak directly into it. Okay?
What I want to see come out of it is everybody today has been very positive so far about putting the patients, but it is about people have got to make the pledge before they leave after 2 days, because otherwise what difference has it made and what difference does it make that you've got a patient panel in front of you?
Thank you. Ed, would you like to comment on that?
I agree.
So everybody's to pledge that they really mean it and they're going to make it happen. Other questions or comments? Where? Yeah.
Yes, hi there. What I wanted to know is how can we best support individuals, patients that are working within the system, or rather with the system, as independents, to how can we support those individuals to get included at a strategic level?
How can we support people who want to make it happen? Martin?
I think it's, first of all, that is, if anyone came to the annual general meeting, which we held a few weeks ago, they will have seen that it wasn't the sort of standard AGM. We started with a series of workshops. I had the privilege of leading one of those workshops.
Sorry, what AGM was this?
This was NHS England, right, and the policy we make. I can only speak for NHS England, the way we're trying to engage with people. And actually, I've learnt the lessons over the years that the best place to start is with people who are receiving the services, starting with communities, starting with groups who have particular problems, listening, and then using that feedback and that information to inform how we create our policies and our actions, and then going back and testing that with people again. It's a constant dialogue, it's a constant iteration, and it's a new way of working. And that's what I mean about the, you know, we actually have the wherewithal to do this. And if anyone looks at the way that, I know Olivia's in the room, Olivia Butterworth from NHS England, we're trying to use social media, we're trying to use new ways of engaging with people. And by the way, we will get it wrong, so please come back and tell us when we get it wrong so we can get it right.
Yes, it's on.
I don't think this microphone's working very well. Can we? I'll repeat
yes,
the
that's
question.
on. Yes,
It's on
thank
now.
you. Yes, I wrote 2 pages of notes during this meeting, and during Jeremy's, I kept on writing yes, yes, yes. The questions really I have is that I think everyone is here, and a lot of them are paid to come here, so they actually believe it before they came. What do we do about the people who don't believe it, don't care, and don't listen? I mean, as a transplant patient of over 25 years, how do you convince the pharmacist who tries to tell me, yes, it's absolutely fine to change my immunosuppressive medicine without consulting my specialist, without really consulting me? How do we get to people like that?
Actually, I don't think people have been paid to come here. I think it's the reverse. So hopefully they really want to be here to change it. But I imagine, Martin, you have some influence on commissioners. As Stephen Dorrell said, if commissioners don't commission services which are fit for purpose, why are we paying them?
And I think that one of the things I would go back to is that you look at the NHS outcomes framework. And one of the things that that I was very encouraged by, having worked as a clinician for over 20 years, was that we actually put patient experience on a par with effectiveness and safety. That actually we have not had a system over the last 10 or 15 years that has valued or used the experience of people in the system as a driver for change. So your experience of having someone change your medication in that way and ignoring your expertise, your knowledge, your experience is frankly wrong. And if we were listening to people, we would listen to that feedback and we would put systems and processes in place to stop it happening. And I think there are ways of doing that. I could wax lyrical about this, but on a time basis I won't.
It's been refreshing to hear everybody's presentation so far, as a patient, first and foremost. And also to hear, right from the offset, patients being put first. And I, again, would echo what my colleague said about everybody making a pledge, but also for what Jeremy said about, I've been doing this for a fair few years now, attending conferences and events, and this has a different feeling about it, I have to say. And I just hope that it can live up to it, and that's obviously one of the reasons we're here. But, because it has been talked about, all of this has been talked about in various ways for a long time. And if we can just get it together for once in our lives, I'm lucky now. I've gone on the journey from being a patient to being, a patient rep for different places. I'm a self-management trainer. And so I see it from all levels. And while we can all sit in this room and say, yes, we're going to make pledges, getting out there to the wider public is the really difficult thing. So we need the pledges from everybody in here to say, yes, we're going to go out and spread the word, because otherwise, if it just stays in this room, as much as we all really want it to happen, it won't.
So one of the positive features is that all health professionals are patients as well. When I was Dean of a medical school, I used to say in the address that when they got their degree, I wanted them to remember one thing, and that is one day they were going to be a patient. Right, we're off to our sessions, and we'll reassemble here at 3:15, I think that's right. Thank you. And can I thank our speakers who were brilliant.